For our fourth case, we're going to be discussing a high-risk, de novo, elderly, acute myeloid leukemia patient. I'll be discussing this case, and then we'll open the discussion to the panel after that. So this is a 75-year-old female with no history of prior hematological disorder or abnormal blood counts who comes to the emergency department with new onset epistaxis. She also has been having bruising for the last couple of weeks. No significant past medical history, overall no major comorbidities or organ dysfunction, and she has a white count of 44,000. Platelets are 132. She does have a bone marrow done, same day in the emergency room, shows 55% blast, confirmation of acute myeloid leukemia with no evidence of background dysplasia or fibrosis. And molecular testing shows FLT3 wild type, NPM1 mutated. She does have overall a borderline PS. Let's say she uses a walker, but otherwise no major comorbidities to speak of. So for this patient, the questions we will be discussing to start the discussion are, I'll ask Dr. Weinberg here, if such a patient came to your institution, what would be the tests that you would be rushing? Are there particular, 75-year-old, are there particular molecular genes that people are looking for? Or would they say, no, it doesn't really matter at this age?
Well, you'd probably want to rush the cytogenetics, make sure there's no complex karyotype or other MRC type of abnormalities. Then we would always do NGS panel on all our acute myeloid leukemia patients. Would probably be interesting to see if she has p53 mutation or more favorable mutations like NPM1 mutation. And that would be what we would do.
Now, so she has NPM1 mutation, let's say. How often would you see a TP53 or RUNX1 with NPM1? Does it happen ever? Is it very rare, or actually do you see it routinely?
We do see it. I would say it's pretty rare, maybe 5 or 10% of the time. NPM1 is co-mutated with secondary type of mutations. Those patients usually tend to have cytogenetic abnormalities too, but it could be that they have a normal karyotype. They probably will not have as good of a prognosis as a typical NPM1 mutated AML, but it happens.
Yeah. And Dr. Azeri, so what would be your, there's actually a couple of things here, even in this patient you could think of. So what would be your treatment choices, and what would you choose in the 75-year-old with no MRC and let's say PS borderline?
So as you were talking, I was trying to wonder if we had time to get the cytogenetics back to see if there were complex cytogenetics, because you might think of Mylotarg the current reduced dosing schedule in this type of patient may not be unreasonable. Though I don't know if we have time to get that back just in looking at this case.
If they didn't have complex cytogenetics, you're saying?
Well, the good risk patients, I'm not sure Mylotarg really helped them very much, but in the higher risk, or excuse me, strike that, yeah.
The other way around.
Correct,
correct.
Yeah.
So
in this case,
right.
if we get them back and she's not high risk by complex genetics, maybe this is a case where we could apply Mylotarg in a safe setting, something to think about. Short of that, I think it's a great case for, once again, the combination targeted therapies that we've already been talking about.
Yeah. So I guess you would have HMA-VEN, low-dose IRC-VEN, and then the other one that we almost never talk about a lot of these meetings, but is approved, low-dose IRC Glastagib. Has anybody here used that combination, and is there a particular group or subpopulation that you would think about it? James, Osama?
So we have used that drug. Again, we had that clinical trial also. I think that what's interesting about that data, and you're right, it got overwhelmed by this wave of venetoclax. But I think interestingly, if you look at that data, that was actually a randomized phase 2 study that did show improved overall survival, which is, I mean, hard, that's hard to argue against in a way. But I think one of the things that study allowed was definitely a less fit patient population. So while venetoclax and HMA really did focus on these patients unfit for induction chemotherapy, the Glastagib trial led on patients who might not be fit for HMA therapy by some community standards. So patients with borderline to impaired renal function, patients with impaired cardiac function. And I think what we got out of the Glastagib trial was not this beautiful remission. But we got these durable responses, patients with stable disease for longer periods of time, improved transfusion requirements, that I think is really valuable to that specific group of patients, patients unfit, patients with other comorbidities. And it is appealing because it could be given as home, as you mentioned about your patient. So, low-dose ARC, while it's not something we all embrace every day, and there might be some hurdles we jump through to get it compounded, can be injected at home, and Glastigib can be administered at home. So, I think that is appealing. But I will agree that it's not something we turn to every day. And venetoclax and HMA has been our standard go-to for less fit patients.